Okay. Thank you, everybody who's joined us so far. My name is Chris Buse, and I'm an education specialist in CAMH Education. And I will be supporting this session presentation right now. It's the Opioid Use Disorder among older adults presentation. And we've got Dr. Jonathan Bertram and Marilyn White-Campbell. So I'll just give you a quick run through of their bio statements. Dr. Jonathan Bertram is an addictions medicine physician at the Center for Addiction and Mental Health with a special interest in First Nations outreach and older adults population in the context of pain and addictions treatment. And Marilyn White-Campbell is the geriatric addictions specialist with the Baycrest Behavioral Support Programs for Seniors in Toronto. She's the provincial lead for Behavioral Support's Ontario Brain Exchange Older Adult Substance Use Collaborative. Marilyn was a co-investigator with the Canadian Coalition for Seniors Mental Health Project, which established 4 national clinical best practice guidelines for substance use disorders in older adults, including alcohol, benzodiazepine, cannabis, and opiates, and a co-chair for the Alcohol Working Group. With over 37 years of clinical experience working with older adults with substance use disorders, she's recognized as a pioneer in the field of geriatric addictions. So I'm going to hand it over to you and let me know if you need any help.
Thanks, Chris. Hi, everybody. I'm assuming you can hear me, so let's get going. So the title of the presentation is Geriatric Considerations and Clinical Complexities for Care of Older Adults. And I'll be co-presenting with Marilyn. And in terms of disclosures, so the program has not received any financial support, some in-kind support from the BSO, and that's mainly in the form of technical support for the video presentation that we'll be including. And from a disclosure standpoint, as far as relationships with commercial interests, I am supported by a grant from the Substance Use and Addictions Program from Health Canada for a project that I'll very briefly at the end of the presentation touch base on as it relates to this presentation, as well as another provincial project that's supported by Ontario Health. Other than that, Marilyn and I don't have any other relationships to disclose, and as such, don't foresee any potential bias. So I'll let Marilyn present the objectives. Oh, Marilyn, I think
you're on mute.
Your audio is not working.
No problem, Marilyn. Just 1 second. I'm just going to reset your mic and camera. You'll come right back and we can try that. Hold on, bear with us, everyone, for just a moment. All right, Marilyn. I'd like to turn your microphone and camera on now with the buttons in our video area in the upper right. Let's give that a try.
Okay.
Yep.
Okay, so we're going to discuss the epidemiology and risk factors of opioids and opiate use disorders in older adults, identify some key points in assessment and treatment of OUDs in older adults, and highlight geriatric considerations for the treatment of pain and OUD in older adults. So in terms of the epidemiology, so the incidence of opiate use disorder in the older adult population is about 1.5 in the US and 3% in Australia. We know that older Canadians actually bear the largest burden from opioids, mostly from prescription sources. And compared to all other age groups, older adults have the highest rates of prescription opioid consumption, as well as the highest rates of side effects, overdoses, and mortality associated with prescription opioids. So there's two primary cohorts of older adults who develop opiate use disorders. Those who have been exposed to opioids for many years through drug experimentation. Those are uh, lifelong users and often beginning in adolescence. Some have been identified and treated with OUD, and many have had adverse health consequences. The second group of older adults who develop opiate use disorder is made up of those individuals who are prescribed opioids by a healthcare practitioner, and usually for a pain condition. Some may have turned to the illicit market in order to maintain an ongoing supply of opioids following discontinuation of their prescription by a healthcare provider, and sometimes healthcare providers that retire leaves them to go to the dark web for other for their medications. So some of the risks. I think this is over to you, Jonathan.
Yeah, so regardless of whether this is by virtue of an opiate use disorder or people who are using opiates for clinical purposes or a mix, older adults are at a higher risk of experiencing hospitalization and death from opiate overdoses. That's both a physiological risk and a social complication, which we'll touch on as well. Roughly 4 out of every 10 deaths worldwide were associated with drug use in persons older than 50. And in those aged 65 years and older, 3 out of every 4 deaths associated with drug use were linked to opiates, per epidemiology that was captured in our guidelines with the Canadian Coalition for Seniors and Mental Health. Important to note that data that comes out around people over 50 is useful when we talk about older adult addiction, because a lot of the programs for older adult addiction are actually starting at 55 and over, whether that's for physiological reasons or for funding purposes. So something to keep in mind when you're thinking about both eligible services and considerations for your patients, clients who you involve in treatment. So the physiological reasons, and we thank Dr. Wyman for her slide, on Jennifer Wyman for her slide in a course that she provided for the National Geriatric Psychiatry Addictions course earlier this year, highlights the issues that affect opiate tolerability in the older adult. Higher rates of sedation, respiratory depression, impairment of vision, attention and coordination, risk of falls. Not that these are exclusive to people who are older, but absolutely augmented, far lower threshold for these things. And in many instances, might appear as side effects in a number of people, but translate into adverse events for older adults. And that, of course, has a huge impact on morbidity and mortality and some of the hospitalization data that we'll touch on. A lot of that is a product of metabolic changes as people get older. Decreased first pass metabolism means that person is having much higher levels of morphine, for that matter, any opiate when they are taking this, both especially first time or a novel exposure to a new dose, and also when taking it over time. Enhanced pharmacodynamic sensitivity, so a more pronounced effect with lower doses that you otherwise would not consider if you were thinking about somebody younger. CYP3A4 inhibitors can increase morphine availability, and a lot of older adults, by virtue of the medications that they're on, are at a higher risk of this. opiate-induced neurotoxicity like hypersomnolence, delirium, hallucinations, and things that really complicate pain experiences in the setting of opiate use and opiate use disorder, like allodynia, hyperalgesia, and also other neurological complications like myoclonus tremor or seizures, features maybe. And then risk factors, including high dosage, dehydration, renal failure, infection, metabolite accumulation, and constipation. Constipation um, is complicated for a variety of reasons. Obviously, the material consequences of constipation and what that can create as a problem, but also the potential for delirium, agitation, issues in the setting of encephalopathy. There are also several factors that make older adults more likely to experience an overdose when using opiates beyond the metabolic changes that we included. Taking multiple other medications, including other sedatives, which increases the risk of dangerous drug interactions, higher rate of more severe chronic pain that requires higher doses of opiates to manage symptoms, um, and, uh, and so speaking to the higher risk when it comes to things like hospitalization and overdose, and of course death. Older adults are also at a greater risk of other side effects from opiates, including nausea, constipation, that can negatively impact their overall quality of life. And we kind of touched partially on that already. So those risks ultimately translate into hospitalizations that we have seen bear out in data. A report not too long ago from Matt Downer and Samir Sinha in November of last year looked at hospitalizations from adverse effects from opiates across provinces and territories, 2019 to 2020. And if you follow the color legend on the right, you'll see that very clearly people 65 and over in escalating fashion are at a much higher risk of hospitalization from the adverse effects from opiates. And so, it's something to keep in mind when we think about prevalence and incidence of OUD and, for that matter, polypharmacy in the setting of opiates. That these comes with lots of complications. Those complications don't always have to be bundled under hospitalization, but what that means for the need for acute management and those more urgent sort of situations are that older adults are at a far higher risk. And both amongst that group, but also sort of under the same banner of hospitalization, those people with opiate use disorder who are coming in, whether that's for an opiate toxicity event or another complication of opiate use disorder. When you look at the Ontario statistics, this changes from province to province somewhat, although you do see this repeat in other provinces as well. The 65 to 85 category does represent a larger number of hospitalizations in Ontario than the other age groups. So really important when thinking about the population impact that this has in this cohort of people. And hospitalizations are one thing. Deaths are obviously not always captured under hospitalizations, but obviously representing an even more extreme outcome. People over the age of 50 accounted for 39% of deaths from drug use worldwide when looking at WHO data. And of those deaths in older adults, those over 65, approximately 75% were linked to the use of opiates. Despite these numbers, there's a paucity of data about the many ways opiates specifically affect older adults and about how to care for those who develop an addiction, also referred to as an opiate use disorder. In many instances, and this is not exclusive to to opiates. In many instances, it actually the point at which there's an opportunity for contact screening and assessment, unfortunately, is in the setting of hospitalization or when a person is engaging tertiary care. So recognizing that these are those time points to potentially screen for and assess for opiate use disorder if a person isn't coming in under that specific diagnosis already is really important when it comes to opportunities to engage those who otherwise wouldn't seek care. And older adults are probably at a higher risk of not engaging the system. There's been a lot more discussion about the social implications and the social nature of isolation, but this also translates into problems with engaging healthcare treatment as well. Canadian data that looked at older adults in the setting of toxicity-related deaths looked at all substance-related toxicity deaths. And this was from just a couple months ago in terms of what was published. Data looking at deaths in a 2016-2017 chart review of older adult patients in a Canadian jurisdiction. When a pharmaceutical substance contributed to accidental acute toxicity death, 61% of older adults had a prescription for the substance. At least one non-pharmaceutical substance contributed to 43% of accidental older acute toxicity deaths. And where this relates to opiates in probably the newer feature when we think about how opiates are obtained, are third party on the street when we talk about things like fentanyl. So multiple substances contributed to most of the accidental deaths, 61%, with fentanyl, cocaine, and alcohol most often contributing to death. Almost 3/4 of the older adults who died of acute toxicity had access healthcare in the year preceding death. The question is, did the treatment that they needed was that properly identified and provided? Sometimes it is, but simply not engaged, and other times, of course, simply not available. So when looking at opiate-related toxicity deaths, OUD prevalence is overall probably lower in older adults relative to some of the other age groups. But with that said, there's probably a huge cohort of people that are being overlooked. For those who were treated for opiate-related toxicity, only 35.9% were identified as having opiate use disorder in the 5 years prior. And this is really important when we're talking about older adults. This is really important because this, unfortunately, sort of dovetails with data that looks at an insufficient intervention for those individuals who are admitted to hospital for opiate toxicity related encounters. Despite a rising prevalence over time, only 1 in 18 patients were dispensed OAT within a week of discharge. These findings highlight missed opportunities to initiate therapies proven to reduce mortality in patients with OUD. Reconciling that with data that's come out very recently in a Public Health Ontario report for the population at large, less than a third, I think it even might be less than 25% of people who came in with opiate toxicity related or opiate use disorder related presentations to tertiary care were taking indicated opiate agonist treatment in the month before their death. So there's clearly a gap when it comes to identifying if people need treatment and being able to better engage people in treatment after acute events like these. So I'll leave it to Marilyn to address the first question that jumps out. Are we doing a good job assessing OUD, and are we doing that in older adults at all?
So are we looking at screening and assessment? We see that older adults don't consistently engage in hospital services for opiate use disorders. Are we using older adults specific tools? So we know that the PDUQ recommended in the CCSMH guidelines is, it's a good screening tool, but it's not older adult specific. So so we're really not doing a great job of screening for OUDs in older adults. So I want to just talk to you a little bit about Sylvia. This is a lady that is 68 years old. She's a non-insulin dependent diabetic. She's got diabetic neuropathy. She has spinal stenosis and had 2 unsuccessful surgeries. She was initiated on fentanyl about 15 years ago, and is now presenting in the hospital. And she has 120 micrograms patch once a day, and she's come to the hospital for a fall, and when they ask her about her use of fentanyl, she denies that there's a problem, but she does disclose to a social worker that she starts to feel uncomfortable if the patch falls off. And then they've pulled back a little bit on the fentanyl. She goes home on 100 micrograms, and she comes back to the emergency department 2 subsequent times for the same thing, same presentation. So she agrees on the third admission. She agrees to go to hospital for rehab because she's not walking very well, and so the focus is to improve her mobility. And there's been no change in her medications, and even in rehab, she continues to fall, is not doing all that great, but is very motivated to go home. So what would you do? So let's say you use your best motivational interviewing, but she's still denying that there's a problem. What treatment would you offer her, and what steps would you take if she declines treatment? Wonder if there's opportunity to put some answers in the chat, or I'm just going to move this ahead a bit because we're going to ask Andrew to play the video shortly. So one of the things that I just want to point out is that the motivational interviewing in the world, if somebody's pre-contemplative, you're not going to get them to admit, and yet there's still the issue. So when I met this lady, what I said to her is that it may not be there is, the medication does cause addiction. It's not your fault. You have a legitimate pain that you're taking this for, but it's about the consequences of it. And is the medication doing more to you than for you? And and we'll link that to the falls, and that's when the light bulb went off, and that's when she said, yeah, maybe there's something to this, because all the other hospitalizations really didn't yield any results, and she kept coming back. So let's Andrew, if you could please play the video.
I'm Sharon Oswald, and glad to be here today. I work as the Provincial Lived Experience Coordinator, and I work with the Behavioural Supports Ontario Provincial Coordinating Office in partnership with Brain Exchange. And my role is to coordinate a group of older adults who are living with dementia, substance use, mental health, and other cognitive impairments, and their family and their care partners. And the idea behind the Lived Experience Network is to hear the stories that people are living with. How can you plan and provide and evaluate services without ever asking people what's working for them and what needs to change? And so today I'm pleased to be here interviewing Sylvia. Sylvia, would you like to share a little bit of your story with us?
Certainly. I'm an older adult. I'm 66 years old. Over time, developed, health problems that a lot of people develop as they get along in age, like osteoarthritis. I had a great faith in my doctors, that I was getting prescribed good medication, and never really gave it a lot of thought. And I guess back, about 12 or 13 years ago, I wasn't on as much medication, so it wasn't as much of an issue. I found that as time went on, the regular medication wasn't working. The pain was getting really bad, and so I was prescribed fentanyl. Didn't know anything about it. Trusted that my doctor was prescribing something that was good for me. And one of the things I always did was read the little pamphlet that comes with your first prescription. And it really didn't give you a lot of warnings other than to not stop taking it without medical supervision. And so I thought a lot of my medications said that, so I didn't think that anything of it. couple of years down the road, I switched doctors, and the new doctor just kept prescribing the fentanyl, and as the pain got worse, the dosage increased. And it wasn't until last year that things kind of really sort of came to a head. I had my daughter passed away, had to sell the house. I had all these things happen to me, and I started falling. And we couldn't figure out what was causing these falls, but it was a concern because I lived out in the sticks, and there was nobody around. I had no immediate family that it was anywhere close. And so CCAC started coming around, and that's when they introduced me to Marilyn White-Campbell, who is the addiction specialist with the Mental Health Association. And at first I kind of thought, mental health is there something about me that I don't know, because I wasn't used to all these agencies around me, and I wasn't sure if there was something that they saw that I didn't know about. I didn't realize all the things that the fentanyl was doing to me. I had pretty well isolated myself, and here I was out in the middle of nowhere, and I had really no friends or anybody. I got involved with the church thinking that was an avenue that I could get meet some people through it. But the problem was that the weather in the winter was so bad that anytime they had anything going on, you had difficulty getting in because the roads were so bad with the snow and everything. But other than that, I just found I wasn't really doing much. I wasn't, I just was on the computer. Now when I look back, I realized I was so lethargic and just not, just didn't really do anything, and didn't realize that it could be related to medication.
Okay, thank you. So, what happened with this lady is that she went to a RAM clinic and did an overnight stay, and was switched over to buprenorphine or Suboxone, and she within 24 hours she was really feeling quite well, and she was able to go back home and sort of pack up her household belongings and move into retirement residence. And one of the things that struck me about that is that when she came in, she was in really severe withdrawal, and you don't do that now. You would do a micro induction, but what struck me was that she when she came in, she said, if I'd known it was going to be this bad, I wouldn't have done it. And I also, if you have a gun, Marilyn, if I have a gun, I would shoot myself. So she was really feeling very poorly. And then the next day she got up and she was able to put her own shoes on for the first time in a long time. And she said this even helps with the diabetic neuropathy. So she was really pleased with the outcome, and even 5 years later was doing extremely well on medication. So in terms of other screening tools for pain in dementia patients, because that's another population that where there may be an opiate use disorder, but if the person is in a long-term care setting or at home and has dementia, how do you assess for pain? So there is the Abbey Pain Scale, there's the Pain AD, and the other thing to take into consideration in a care setting like long-term care or retirement is the person experiencing some anticipatory pain. For instance, if you're providing wound care, one of the things I've seen happen many times is that when someone has a stage 4 pressure sore, and when the nurse comes to the person and they just touch them, they just hit the ceiling and they strike out. So there needs to be some considerations, perhaps maybe even a PRN 20 minutes before you provide care. Because if you think about it, if people, they're sitting in their wheelchairs or they're not very mobile, and you go to pick them up to transfer them into their wheelchair or back into their bed, they're sore. They're very sore, and it's not, it's not it's not drug seeking that they're saying I'm in pain. They really are in pain. They're pain relief seeking. So sometimes having something in advance that using judiciously the PRNs. So here's an example of the API pain scale. So you're looking for vocalizations, facial expressions, behavior changes, and that's where you see a lot of striking out. Physiological changes in temperature, pulse, blood pressure, etc., and some physical changes. So all those things, have a watch for those. And I'm going to turn it over to Jonathan to talk about the senior alcohol misuse indicator.
Yeah, so we don't want you to be confused as to why we're talking about an alcohol screening tool. We haven't forgotten what we're presenting on. The reason for bringing this up is mainly because, well, for one, when talking about screening in older adults, where there's better evidence, where there's tools that seem to be really tailored towards older adults, you're more likely to find them in alcohol. You're more likely to find a few kind of multiple tools that are able to do that and have been tried out in older adults as well. Most of the screening tools for the other substances, including opiates, are really based more on expert opinion as opposed to an evaluation of their effectiveness in older adults. But the SAMI in particular is one that uses language that is one, focused more on symptoms than on substance, and two, works to work in a discussion about substance almost in parallel. This should not be a substitute tool. If you read down the list, you'll see there's a very clear line of questioning that considers essentially the socialization of alcohol. And that might be appropriate in certain substances like alcohol and cannabis, but far less likely to be appropriate when we're talking about, or at least prevalent anyway. Maybe appropriate is not the right word, but prevalent when we're talking about older adults. And so, section 1, where it's asking about any problems that a person has experienced, whether that's changes in sleep, drowsiness, changes in appetite, weight, poor balance, is really getting a person to sort of talk about their most troublesome symptoms, their problems. And if they've recently experienced any of those problems, in addition to others like feelings of sadness, loneliness, anxiety, essentially mental health affective problems. And the idea there is to then follow that up with getting the person to comment on their use of alcohol, whether they enjoyed it, whether it has changed over the years. It would be a lot harder to do that follow-up line of questioning with opiates, but in a setting where you've got a person taking medications, it might be a bit more straightforward to follow up with questions about their pattern of opiate use after having screened any problematic consequences that they're running into. And then the last question at the end, question 5, you mentioned that you have difficulties with 1A, 1B. I'm wondering if you think that, and this is where you might at least be able to have a bit more of a straightforward dialogue about whether or not they think opiates could be connected. And what's interesting is Sylvia speaks to, Marilyn being able to do that in a very direct way, albeit probably one where more of a relationship connection was established. And in your office, when you're seeing a person, whether that's for the first time or for a short time, if you're wondering or not sure about whether or not opiates need to be talked about a little bit more, this line of questioning and this style of questioning might be a bit more useful than having them fill out the PDUQ prescription drug use questionnaire in the office or anything along those lines. And screening often in these types of settings should probably be done as an interview style, as opposed to just a questionnaire that a person fills out. Understanding how much more efficient it is to have screening tools being done in the waiting room while a person's waiting, or in the room while they're waiting to see you. But in these types of situations, you're still likely to miss what it is that you're screening for. And with this cohort of people, that just becomes higher. What you can't do with the SAMI in the setting of opiates is score their answers to these questions in order to figure out whether or not this is a person who is using problematically. But what it might allow you to do, and that, by the way, what I'm showing you right now is kind of the scoring index for the SAMI, which I think would be totally appropriate, whether it's alcohol or cannabis, and certainly evidence-based for alcohol. But what it might allow you to do after doing that line of questioning is open up a larger discussion about substance use disorder, whether that's using the DSM-5 criteria to ask a few more questions to better characterize that person's pattern of use and behavior, understanding at the very bottom there that things like tolerance and withdrawal are not as easily applicable in the context of medically supervised pain management, and that some of the questions around occupational function and major obligations are a little difficult to nuance in an older adult, where there are probably lots of other circumstances, incidental, transitional, that relate to why they don't carry out as many of the major obligations that they used to. So something to keep in mind when you are having this type of conversation, if you get the opportunity to have this kind of conversation in the context of diagnosing opiate use disorder. But if you do, and if it is established, and then it's an opportunity to, in some way similar to Sylvia, identify a next step in treatment, we're going to review some of the guidelines from the CCSMH on what could impact influence treatment. So I will hand it over to Marilyn.
So here you have the QR code for to download the opioid guidelines. So if you want to get your phones out right now, you can click on or take a picture of the QR code, and it'll download it to your phone. So the Canadian Coalition for Seniors Mental Health developed these guidelines in 2019. And we're hoping that you'll be able to use those and reference those in your clinical practice.
So some of the basic guidelines that are sort of material to steps you can take in a treatment setting, we tried to outline here. These are not all the guidelines, just some highlights. And again, things that might be relevant to practice. So number 14, induction onto an opiate agonist is recommended over withdrawal management. That's just as much of a mainstream recommendation as it is for older adults. But also really important when talking about the really low threshold for consequences from withdrawal that older adults are more likely to suffer for some of the same reasons as was outlined with the slide on opiate tolerance, but also some of the things that we know are maybe treated like side effects in the setting of opiate withdrawal, but are probably more adverse events when we talk about issues with balance, gait, drowsiness, and confusion for an older adult. During opiate withdrawal management, adjuvant medications can be used with caution due to medical comorbidities, side effect risks, and other concerns related to older age. And buprenorphine maintenance should be considered first-line treatment for opiate use disorder in older adults for reasons that we'll outline, that are both, not entirely different, but certainly specific to older adults as well. We advise patients that the use of alcohol, benzos, and other sedative hypnotics can be hazardous when combined with opiate agonist treatment, but we also provide the same counseling that that represents a lower risk when we talk about buprenorphine. And early take-home dosing for buprenorphine maintenance may be considered, including home induction in patients who are at a low risk. They find it difficult to attend the office and withdrawal, and if the patient has social supports at home. And these are really applicable across the board when we talk about people with opiate use disorder, but absolutely amplified, augmented, highlighted when we talk about older adults in the setting of their physiological and social restrictions. So some basic principles. if you've got a person on their medication for OUD, you've engaged them in treatment, really important to, ideally practitioners are, tailoring and making changes in response to what they know and don't know about the person that they're seeing with regard to starting or tapering medication. But as a general principle, that should always be respected when thinking about an older adult. Some real concrete recommendations would be reducing initial doses of medications for OUD by 25 to 50% if you're thinking about that person's tolerance, slowing dose escalation frequency again by a similar percentage, and using the lowest effective dose to suppress cravings, withdrawal symptoms, and drug use, and monitor this closely. So, this was very much more and these are under the GRADE recommendations, more a product of expert opinion and a discussion amongst the team that was part of the working group for opiate use disorder guidelines. But I think very much in the spirit of what's of both what we know about a lot of our patients and don't know enough of around older adults in the evidence. The threshold to admit an older adult with social, psychological, or physical comorbidities to either residential or hospital care for opiate withdrawal management or induction onto medications should be lower than for a young adult. And I would say for both the reasons of safety and from the standpoint of where older people are a lot more vulnerable to the social pressures that come in the setting of living alone or not having access to as many services and outlets as others in the population. And for severe acute pain that's been unresponsive to non-opiate strategies, a short-acting opiate, in addition to opiate agonist treatment, may be considered for a short duration, less than a week, and then tapered if necessary in settings where I would say you're worried about the extent to which pain could either provide a dangerous limitation to that person's function or invite coping behaviors that are dangerous. So the advantages of using buprenorphine in these types of settings are fewer cognitive and psychomotor effects, no changes in patients with renal impairment dialysis, safer in patients with both liver failure and renal failure, less hyperalgesia, less constipation. Important to acknowledge that does not mean no hyperalgesia or constipation, and at therapeutic concentrations not predicted to cause clinically important drug interactions with other drugs metabolized by major hepatic P450 cytochrome. Fewer drug-drug interactions as well in the setting of buprenorphine. And this also, transfers to considerations for pain management in older adults as well. Some of the pain-related issues that we're often worried about are opiate withdrawal-related pain. Lynette Reeb, who was the co-chair for the opiate working group, and a colleague has published on this with regard to site-related withdrawal pain in the setting of opiate withdrawal, but also opiate withdrawal that exacerbates existing pain. How many of these Canadians subject to tapering of formulations such as codeine, oxycodone, and fentanyl are actually receiving adequate pain control? And in turn, how is that affecting them as older adults? And exacerbated by the availability of non-opiate pain therapy treatments, this continues to be one of the biggest reasons why medication is front and center, both as a problem and a solution, because of the lack of non-opiate therapeutic outlets as a complement or co-treatment for people with complex chronic pain. Buprenorphine in pain treatment is an encouraging agent. It is not the solution in and of itself, but in many situations can really improve a person's situation, and Sylvia's is a great example. Pain relief equivalent to full mu agonists, I think, is variable depending on who the person is that's receiving these agents. But there is an opportunity for analgesia, especially with low-dose buprenorphine. It's effective. It can be effective in neuropathic pain, and that's been shown in a small number of studies. Be interesting to know whether this is pain that's purely neuropathic or what's become more and more recognized, nociplastic pain. That's a much more complex sort of pain that we see. It mimics a lot of those other types of pain. Split dosing of buprenorphine seems to be more effective for pain than for withdrawal. And sometimes it's that a person needs a consolidated dose to manage their withdrawal, and then it gets split dosed in the setting of pain. And it seems to mitigate things like opiate-induced hyperalgesia. In fact, in a lot of settings, that's where people see the most remarkable progress from being inducted on or transferring to buprenorphine is it mitigating that type of hyperalgesia. And preliminary trials suggest a plausible role, but there is a paucity of high quality evidence. And I think in a lot of ways, the best way to sort of contextualize that last bit is that ultimately, if you're helping any person, but for the purposes of what we're talking today, an older adult with pain who's on opiates and high dose opiates at that, a transfer to buprenorphine is one where you're trying to address issues around withdrawal, you're trying to address issues around opiate-induced hyperalgesia, side effects of being on full mu agonist opiates, and ideally also improving their pain. So much of chronic pain management is in line with the GRADE recommendations, which is improving function just as much as it is, if not more than it is, reducing their self-reported pain score. And in that setting, buprenorphine is already an agent that does that, but still lots more to study. Okay, Marilyn's going to touch on geriatric considerations.
So in terms of geriatric considerations, you want to look at the consequences of withdrawal in the context of the older adult and what are some of the danger signs and symptoms of the physical withdrawal. So we certainly use the CAWS scale, but for older adults, the nausea, vomiting, that if they become dehydrated, that can sort of turn the page a little bit in terms of how they're managing, and it can quickly turn to delirium. So sweats and anxiety, and there are some adverse effects in older adults. So as we talked about, and you saw in the video too, the instability, the falls, and we keep talking about constipation, but really in geriatrics, that's one of the things that you always want to watch for. So in terms of, this one, I think I'll turn over to you, Jonathan.
Yes, I get a brief. I get a brief appearance, and then we're back to you. Yeah. Just some material tips then in the setting of buprenorphine. So consider briefly supervised buprenorphine microinductions, where maybe they come into clinic, you're seeing them at the beginning of the day, ensuring that there's no obvious allergy or initial response that would have you concerned, like sedation, drowsiness, and of course precipitated withdrawal with buprenorphine. Although with microinduction, you're obviously mitigating against that. And then consider providing buprenorphine carriers as a means of lowering the threshold for access, mobility, transport. This is something I do often in my community clinic. I work a day a week in Bowmanville, out near Oshawa, and buprenorphine microinductions, where it's supervised in a family health organization office, so a FO office, is doable as long as you've got a very, very predictable, transparent protocol. And an opportunity to use a nursing office or a patient room, depending on whether or not it's a slower day or a day where other colleagues are maybe seeing patients in the afternoon. Pre and perioperative considerations, a discussion with the hospital team about how buprenorphine can be administered, because that obviously continues to be a learning point. And that, twice a day, 3 times a day, 4 times a day regimens are reasonable for people to be started on even in hospital and then discharged with, and that induction can take place. Doesn't necessarily have to be before while they're in hospital. It can be done before they go into hospital, and then discussion with the team about any concurrent analgesic management, and the possibility of assessing even transdermal buprenorphine for pain initially, which would be at least logistically a much smoother introduction. And those would be ways to really mitigate this particular recommendation around opiate withdrawal management that really pushes on only offering opiate withdrawal management for opiate use disorder in the context of connection to long-term addiction treatment. This would probably not be as applicable in a pain setting, and so something to consider if you're looking at the guidelines and trying to apply it to buprenorphine induction.
So we want to just touch a bit on stigma and opiate use disorder in older adults, and you can see in this comic that's the gingerbread is being sort of told, can you just try and ice your knee? Well, older adults do have legitimate pain, and they're most likely to be prescribed medications for legitimate pain. So it's something to take into consideration when you are looking at transitioning someone to long-term care, for instance. If you have someone who is on methadone, it really is a barrier to admission to long-term care. There's cost and administrative challenges. So some homes simply can't manage someone who's on methadone because the pharmacies that serve the long-term care homes don't dispense it. So that it's not, they're not always using brick and mortar stores to pharmacies to get their medication. So I've come across that many times where someone comes into long-term care and they're on methadone, and they literally within the day that they set toe in the long-term care home, they have to be taken off of their methadone because there isn't a way to get them their methadone. So as part of transition to long-term care, that's something that maybe to take into consideration. Um, and where there's a history of substance use disorder, that history that comes with them on their chart can be a concern to long-term care homes when they're applying. And again, some of the homes may not accept them because they're not equipped and understanding how to support someone with an opiate use disorder. So again, microinduction, if appropriate, as part of that transition plan, should be considered. And the other thing that happens once people get into long-term care and they have the diagnosis of or the label of opiate use disorder, when the person comes to the nursing station and they say they're there 10 minutes early and they say, "Can I have my pill now?" They're seen as drug seeking rather than relief seeking. So we've had to do a lot of education with long-term care around opiate use disorders in older adults. So we are trying to support long-term care homes through the Behavioral Supports Ontario, and doing some education around opiate use disorders. Um, and also around the use of PRNs. Some residents are refused PRNs completely because it's seen as drug seeking, and then other ones, the PRNs are being used regularly, and so is the person being perhaps undertreated for pain if they're taking all of their PRNs. So it can be very confusing for both the patient and for the staff. So something to take into consideration. So I'm going to let Jonathan talk a bit about his programs and some of the resources that are available to you provincially and locally.
Yeah, we basically drew from the CCSMH guidelines. A lot of what was in those guidelines was drawn from CRISM that was put out in 2018. It does not include a lot of the, I think, great literature that's been put out by Medify in response to a lot of the urgent issues, especially around the toxic drug supply. So we didn't include that here because we were really speaking to what the presentation was making reference to. And a lot of the issues that we're seeing in older adults in the community are in part what inspired some work that I've done on with the help of Ontario Health, working with Andrew Smith at iPark the medical director for IPARC at CAMH, to do some pilot engagement with primary care sites around remote and in-person, virtual and in-person pain and opiate use disorder treatment. The other sort of work that's been inspired by what we found amongst people with opiate use disorder, and that obviously includes older adults, is a project that they're working on with Health Canada, with SUAP, Substance Use Addictions and Addictions Program at Health Canada, around engaging opiate use disorder clients with a peer support worker and a care navigator to improve their engagement in treatment, to try and address that particular statistic around opiate toxicity related hospitalizations, events in the prior year where a person was not subsequently inducted on OAT and did not continue to take their OAT. And a lot of the insight, and I don't know if Sylvia is Waterloo Wellington, Maryland, maybe she is, but a lot of the insight that we brought to this presentation comes from work that Marilyn and I both do, that Marilyn actually has introduced me to several years ago, in fact, with both of these programs. COPA, which is the Community Outreach Program and Addiction Service under Reconnect Mental Health Services, working in the Toronto catchment, and CMHA Waterloo Wellington, who really, in my opinion, provide a unique service in this province, in the setting of community outreach in conjunction with specialized geriatric services. And I work with a nurse and nurse practitioner who do some great work doing outreach, engaging both community services and the hospital for older adults at the point of care, point of crisis, point of care, depending on their situation.
Okay, so here are our references. You can see those if I think you can download the slides. And so we now have about a couple of minutes or 5 minutes for questions.
Or two.
Or two. Do we
if
have
there's any
questions?
in the chat, or if people wanted to unmic. I guess Chris will defer to you if you wanted to moderate that now. Okay.
Also, for those of you who are practitioners in the Toronto area, if you have someone who is on the waiting list to long-term care and they're experiencing barriers to getting into long-term care, you can certainly refer to my service over at Baycrest. Reach out to me at that email address or through Behavioral Supports Ontario at Baycrest, and I can help to facilitate the application and make sure that the homes that the person is targeting, that they're able to support someone with opiate use disorders. Because there's a handful in the city.
So I don't see anything in the chat for questions at the moment. So last call, if you have anything, please fire it away. In the meantime, I just want to thank both of you, Jonathan and Marilyn, for a very informative presentation. You can definitely tell that you're very devoted to this population group. Thank you.
Thanks, Chris.
Thanks, Chris. Thanks, everyone, for attending.